Okay,
Good
sorry, you can
morning.
let the journalists in now. So Mary, we will start in about 2 minutes when the journalists have joined us. We just had some audio issues with people drilling, but I think it's fixed now. Thanks.
All right, letting the journalists in now.
Okay. Can you alert me when we are ready, please?
Yes, I'll send you, I'll tell you.
Thank you.
Okay, Mary, we can start. Thank you.
Good morning. Welcome to the WHO Africa Media Briefing, which is taking place in collaboration with the APO Group. My name is Dr. Mary Steven. First, some housekeeping. You can listen to this press conference in either English or French. To do this, please go to the bottom right-hand corner of your screen, click on the globe icon and select your most preferred language. Maya, can you please explain in French?
Oui, bonjour à tous et bienvenue à cette conférence de l'OMS. Si vous souhaitez écouter la conférence en français, vous pouvez cliquer sur l'icône en forme de globe qui est située à droite tout en bas de l'écran et ainsi vous pourrez sélectionner le langage choisi. Merci beaucoup.
Merci beaucoup, Maya. And now joining us from Brazzaville, the Republic of Congo, is Dr. Matshidiso Moeti, the WHO Regional Director for Africa. Dr. Moeti, welcome, and I hand over to you to introduce our remaining panelists.
Good day, bonjour, and welcome to all the journalists who are joining us for this press conference. While we'll give you the latest on COVID-19 and other outbreaks that have captured world attention, today I'd like to focus on a disease that threatens hundreds of millions of Africans, but has somewhat dropped off the radar. Meningitis is taking an enormous toll on our countries, with COVID-19 threatening some of the extensive gains that have been made in the past. I'm very pleased to be joined by meningitis immunization advocate, Professor Françoise-Marc Laforce, who is the Director of Technical Services at the Serum Institute of India. Professor Laforce played a pivotal role as the director of the meningitis vaccine project in the successful development and widespread introduction of the Group A meningococcal conjugate vaccine, MENAFRIVAC. This was the first internationally licensed vaccine to provide long-lasting protection against sub-Saharan Africa's most important cause of epidemic meningitis. I'm also very honored to be joined by Mrs. Omorodion Roda, Executive Director of the Care and Development Center in Nigeria, and a high-level advocate for vaccination against meningitis. A very warm welcome to both of you, and thank you for joining us. The defeat of meningitis Group A is one of Africa's biggest health success stories, with not a single case being reported on the continent in the past 5 years. Now, however, the COVID-19 pandemic has delayed vaccination campaigns targeting more than 50 million African children, raising the risk that these gains will be reversed. In addition, major outbreaks caused by meningitis Group C have been recorded in 7 of the African sub-Saharan meningitis belt countries in the past 9 years. The most recent was a 4-month outbreak in the Democratic Republic of the Congo, which claimed more than 200 lives just last year. Pandemic-related disruptions saw meningitis prevention and control services slashed by half in 2020 when compared to 2019, followed by only a slight improvement last year. In 2010, it was strong political commitment that drove the deployment of the very effective vaccine MENAFRIVAC that I referred to earlier. Africa's health ministers had issued a desperate plea following an outbreak 14 years earlier that infected more than 250,000 people, killing 25,000 in a matter of months. That vaccine has now reached more than 350 million people with significant results. In 2004, half of all meningitis patients lost their lives. Last year, 95% of them survived, clearly demonstrating the powerful public health impact of vaccines. MENAFRIVAC specifically was developed through a unique partnership between WHO, the Gates Foundation, and PATH. It is a lesson to all of us of the swift progress that collaboration enables, and one we should remain mindful of as we tackle not only meningitis, but also other health threats like monkeypox. Today, WHO in the African region launched an ambitious new strategy, the Regional Framework to Defeat Meningitis by 2030. One of its priority interventions is the rollout of a next generation vaccine that has been shown in clinical trials to be safe and effective against multiple forms of meningitis. Community acceptance, which resulted in 95% can be achieved. Following this example, the new framework aims to roll out the new vaccine to all 26 meningitis belt countries between 2023 and 2030, aiming to achieve 90% coverage. WHO is expected to pre-qualify this vaccine by the first quarter of next year. I'd like to urge all our member states to prioritize implementation of the strategy now, before the start of the meningitis season in January 2023. WHO COVID-19 threatening the immense gains made against meningitis, we cannot drop our guard. Turning now to COVID-19, the African continent has seen a 6-week decline in cases, with levels now down to those being reported in the very early days of the pandemic. In the past week, the number of new cases dropped by more than 44% compared to the previous week, and the number of deaths also decreased significantly by 41%. However, we still need to sustain our interventions, particularly vaccination. Meanwhile, for monkeypox, there have now been 581 confirmed cases and 12 deaths across 11 African countries. The majority of cases are in Nigeria, the Democratic Republic of the Congo, and in Ghana. And of the 12 deaths, 6 occurred in Nigeria, 4 in Ghana, and 2 in the Central African Republic. Although not a single monkeypox vaccine has been administered in Africa, WHO's provision of 39,000 test kits to countries has resulted in improved testing rates. These are small steps forward, but we are seeing improvements in surveillance and risk perception. WHO's guidance on infection prevention, control, and treatment of monkeypox has also been adapted to train healthcare workers in all the affected countries. Fundamentally, however, Africa is still not benefiting from either monkeypox vaccines nor the antiretroviral treatment tecovirimat, the only doses of which have been administered in a small study in the Central African Republic on the continent. Without equitable access, the inherent danger for countries responding to multiple outbreaks is that monkeypox is allowed to become one more preoccupation that absorbs the capacity within very challenged health systems, adding an unnecessary burden that these countries can ill afford. So I'd like to reiterate our call for a coordinated global response, including equitable access to the available tools to address the monkeypox threat across the continent. Thank you very much for joining us, and I look forward to our discussions today.
Thank you very much, Dr. Moeti. And now turning over to you, Professor Lafosse. Can you please tell us how meningitis vaccines are making a difference to defeating the disease? Welcome, Professor Lafosse.
Thank you. My comments are really quite straightforward, given Dr. Moeti's excellent description of what has transpired. I became involved in this project in the year 2000, 2001, And I've seen a transformation occur. That transformation has largely occurred with the development of the Menafravac vaccine, a vaccine that was designed specifically for the African meningitis belt. And over the last 12 years, about 350 billion Africans have received a single dose of this vaccine, and the disease has disappeared in every country where campaigns have been done. It is worth remembering that to this date, approximately 600,000 or between 600,000 to 1 million cases of bacterial meningitis due to Group A have been prevented. This is an enormous success, and one that I think we should all take great pride in. Furthermore, and as Dr. Moeti pointed out, we have residual focal epidemics of MEN-C, MEN-Y, MEN-W, and MEN-X, particularly MEN-X and MEN-W. A new vaccine, again, specifically designed for the African meningitis belt, will hopefully be pre-qualified later this year or early next year. But this vaccine holds the promise of finishing what Menafravac began, or such that Africa may be the first continent to be free of meningitis epidemics. On that note, thank you for your attention.
Thank you very much, Professor Lafos. And now turning over to you, Mrs. Rhoda. Could you please discuss the lifelong effects meningitis takes on both patients and their families? Welcome.
Okay, thank you very much. Just like others have spoken, looking at the adverse effects of meningitis, I've asked to talk about the lifelong effects of meningitis on survivors. As we all know, meningitis can cause a range of health problems that can often and their families are left at pity. This can include such things like hearing loss, epilepsy, seizure, loss of coordination. You just speak there. And that 1 person in every 10 that contract meningitis is likely to die. And in Africa, 1 person out of 4 persons that survive meningitis definitely will end up with severe complication. And such complication, like I have listed, includes epilepsy, seizure. And in most cases, you discover that such complications are not easy to manage, especially in countries in low and middle-income countries like ours. Communities, meningitis survivors, they often have healthcare needs requiring long-term medical treatment. Unfortunately, like I
Okay, we seem to be having a challenge with Mrs.
I'm back again. So,
okay, we are having challenge with your connection.
like I was saying,
Okay, Mrs. Surya, I will come back to you.
You hear me?
Yes, your internet is breaking. I'll come back to you. I'll come back to you. Yes, I'll come back to you. So to journalists, we have an opportunity for asking questions. I'll come back to Mrs. Rhoda and we'll try her once again. So to do this, you can use the Q&A function on your Zoom platform. tell us your name and the name of the media organizations you represent. And to answer your questions, we also have additional experts here. Dr. Apaku Palu, Strategic Planning and Policy Team Lead for Communicable and Non-Communicable Diseases. Dr. Fiona Braca, the Team Lead for Emergency Response. Dr. Tiano Balde, the Regional Incident Manager for COVID-19 Response. Dr. Andre Bita, the Regional Meningitis Control Officer, and Dr. Fiona Atubube, the New Vaccines Officer at WHO Afro. So if you want to go live, you could also tell us in the chat that you want to go live. Mrs. Rhoda, let's try again and see if your internet works before we start taking the questions.
Can you hear me?
Yes, we can hear you.
Okay, like I was talking about the effects on individuals, families, and communities of meningitis. I said that meningitis survivors are dependent on family caregivers, which can result in significant financial, emotional, and logistical pressure on the caregivers. People that survive meningitis, due to the severe effect, they find it difficult to take care of themselves. So they need caregivers that will take care of them, and those become a challenge to the caregivers. Equally, survivors of meningitis are also faced with the effect of stigmatization. In most African countries, where they believe some certain health issue as a result of some spiritual or some myths and superstition, you have people that survive meningitis facing a lot of stigmatization as an effect. What would people living with meningitis do? As a person that survived meningitis, we encourage the person to live a fruitful life. The person should live with the effect and accept that this is a situation, so the person should brace up with it and seek medical attention, medical care and support from the family and from people that can support him or her. Caregivers should as well seek for reliable and credible information and that will aid them to give proper care to the survivors, because it's actually not easy to take care of the survivors. So they need credible information to help them. We equally look at the religious and community leaders. We encourage that there should be massive sensitization about meningitis to religious leaders and community leaders. By so doing, the issue of stigmatization would be eliminated or minimized. We encourage donor agencies to equally integrate meningitis as an area of intervention. We encourage the government sectors to create a form of social fund, because taking care of meningitis is actually enormous. So there should be social funds to help survivors to be able to meet up with some of their needs and their caregivers to continue to render help to them. Can meningitis be prevented? I would say yes. Some pathogen of meningitis can be prevented. And the best way to do this is vaccine. But there are some areas in Africa that we know that access to the vaccine may be limited or not available. In such situation, we encourage that people within that area must be able to know the signs and symptoms. Knowing the signs and symptoms become very paramount to them, because we know that meningitis is an emergency situation. So if they know the signs and symptoms, they'll be able to follow up immediately to take such person when they notice such thing for medical attention. We also encourage that when people notice any of the signs and symptoms, it is important that they follow their instincts and immediately seek medical help, because meningitis is an emergency health concern and can kill within hours. We hope that the government, donors, civil society organizations, and individuals should be able to work to ensure that this plan, this regional framework that is being launched today, is being implemented and the resource being utilized effectively. The voice and experience of people affected by meningitis should be key for us in making plan a reality and ensuring that together we can defeat meningitis. On behalf of Care and Development Center and Confederation of Meningitis Organization, we congratulate everyone, we congratulate Africa for this great stride, because Africa is now the first to achieve this great stride, to launch this document, the regional framework. So congratulations to everybody, and thank you for joining the race to defeat meningitis. Thank you all.
Thank you very much, Mrs. Rhoda. And then we are going to the journalist question. Paul from The Lancet, are you ready to ask your question live?
Yes, yes, I'm ready. Thank you very much. So I have two questions. My first question goes to the Prof. In your speech, you mentioned that Africa could be the first region to eradicate meningitis. So I want to know what do you think peculiarly moves Africa to achieve this feat? And when eradication happens, what is your recommendation regarding continual vaccination, considering what we are experiencing with monkeypox, where the stoppage of smallpox vaccination that used to protect against monkeypox is described as one of the reasons why we are seeing increase in new cases. And for Dr. Moeti, I have a question regarding the recent announcement of the attainment of more than 75% efficacy by the malaria vaccine through the introduction of an additional booster dose. So I want to know, we are also talking about booster doses with COVID-19 vaccination. What is the effect? How is Africa preparing for booster doses across different diseases? And what do you think are there additional burdens and tasks that needs to be done considering booster doses for different diseases needs to be an equivalent task on vaccination officers and structures on the continent? Thank you very much.
Thank you, Paul. Prof, let's have you take the first question, and the second question is to Dr. Moeti. Professor Lafos. Okay, Dr. Moeti, can we start with you while Prof is getting ready?
Okay, thank you. So the question was about the trial that's been being done on a malaria vaccine by Oxford University with some partners, and the fact that the information that's emerged that it is seeming to have an efficacy level of 75%. Of course, this is very good news if that the vaccine has been found that has this level of efficacy, and it's just adding yet another tool in the fight against malaria, which we know is a major killer of African people, particularly African children. And we can only look forward then to the completion of the trials of this vaccine, to the vaccine being made available to join the vaccine that's already, the RTSS vaccine that has been tried out, and where we've done field testing of the rolling out of the vaccine in a number of African countries, and that is now being used in African countries. So we welcome very much this new development, and we look forward to further information, further evolution, the final trials of this vaccine. I think it's only good news if an additional vaccine can be added to the armamentarium against malaria on the African continent and in the rest of the world. I couldn't hear very clearly the second question. I think the question was, how is Africa preparing to provide additional doses of COVID-19 vaccination? And the fact that Africa is a region where we have to use multiple vaccines. How are we working to make that possible? How are we working to create the capacity to do this? First of all, I mean, just to say that we have seen some African countries reach levels of coverage with COVID-19 vaccination. A couple of countries, two, have reached the 70%, and we have quite a number that are between, I would say, 15, 20%, and 40%. We've seen significant increases in coverage of vaccines in several countries like Ethiopia. Once vaccines became available, during this year, in fact, once vaccines became available, and the partners have got together to support the implementation of some quite intense campaigns in countries. So we are very hopeful that there's a new momentum being organized at the global level. We as WHO have played a key role in supporting countries from the very beginning. We encountered the challenge in vaccine dose availability, and now there is a strong partnership that has been established, and we are playing a role in that as well. Actually, at the moment, the African Union, the Africa CDC, is organizing a meeting in Addis on how to catch up and make sure that by the end of this year, all countries have reached 70%. And we are working on various strategies to do this, including very much creating demand for vaccines. I think as far as how the region is preparing for having the capacity to use vaccines as a tool in public health more generally, it really means that we need to invest in the national health systems in countries. We need to invest in making sure that we have the infrastructure, we have the human resources, we have the procurement and supply systems that are going to make it available for vaccines, if they are available, procured in the country, to be sent out to the distribution sites and to have the capacity to deliver those vaccines. I think most importantly, what we are learning about vaccines repeatedly, that was lessons learned for the Menafrivac vaccine, the lessons we're learning very much for the COVID-19 vaccination, is that it's very important to create the demand for vaccines in the population. It's very important that people know the value of vaccines. I think the examples, the testimony of Mrs. Rhoda about the impact of meningitis on people's lives. This needs to be known by people so that parents will be interested in ensuring that their children are vaccinated against meningitis. So we need that entire package of creating systems, including at the community level, that really create the demand for vaccine, and then that create the capacity as well to distribute vaccines and carry out vaccine delivery services, whether through campaigns or integrated into primary healthcare services and routine immunization for children.
Thank you very much, Dr. Moeti. Professor Lafos, are you ready to take the first part of the question?
Yes, surely. The question that Paul asked specifically related to strategies in terms of monkeypox. I will be the first to confess to you that my expertise is largely in meningitis vaccines. And despite the fact that I began my career as a smallpox epidemiologist for the World Health Organization, I don't feel comfortable in commenting on the expanded use of monkeypox vaccine. I would ask whether Andre Bita or other experts at AFRO could help me answer Paul's question. Thank you.
Thank you very much, Prof. Dr. Fiona Buraka, over to you, please. Can you help us answer the first question?
Thank you. I believe it's about the strategies for control of monkeypox.
Right.
Okay. Yes. So indeed, there is a vaccine, as has been mentioned, and we did have the old generation, the smallpox vaccines that are also effective against monkeypox. That is one tool, and we also have a new generation vaccine. That approach is also available, but we do have limitations in terms of quantities of vaccine. However, the other strategies that have been used to control monkeypox outbreaks from the experience in Africa, where several countries have been experiencing these outbreaks since the 1970s, include ensuring that the local communities are aware about the way that disease is transmitted, and that they protect themselves and those that are around them, ensuring that there is no contact to avoid the transmission. It is spread by direct skin to skin or mouth to skin kind of contact. So it's important that there is that separation when it comes to infection. We ensure also that there is adequate surveillance in place to be able to detect these cases rapidly and provide the necessary management. And there is also more recently an antiviral treatment available, but again, very much in small quantities. So I think that it's a collective use of strategies, and for the African region where vaccines and therapeutics are not very much available, we rely more on the other modalities of controlling the spread of the disease. Thank you.
Thank you very much, Dr. Fiona. And now I'm turning to you, Leon, from Daily Nation, Kenya, if you're ready to ask your question live.
Hello, thank you so much. My name is Leon Lidigu from the Daily Nation. I have two questions. One concerns HIV. Now, last week, we did a story whereby a soldier from the Kenya Defense Forces had been dismissed because he had tested positive for HIV, and more so they tested his samples without his consent. Now, this is a big issue because many people are now coming up to say they joined the force, they were dismissed on the same grounds. And I would love to know WHO's position on the military and when it comes to HIV and discrimination, because they seem to be sending these people home because of the fact they call them that they're medically unfit. So I really would love to know, how do we deal with this situation? And number two, how are we then going to contain the spread if we are then discriminating people and denying them employment based on the fact that they've tested positive for HIV? And then my second question has to do with the state of malnutrition in northern Kenya. Now, if you've noticed, Doctors Without Borders have kept on updating on the drought situation, and the situation is in a very critical condition. And when we go to the government tells you it does not have the resources to provide plumpy-nuts and to other ready-to-use therapeutic foods. So is WHO doing anything about this? Because as a country, we honestly seem to be focused much more on politics at the moment than the plight of Kenyans in the north. Thank you.
Thank you very much, Leon. Over to you, Dr. Moeti, and Dr. Fiona, please get ready to respond on the malnutrition as well.
Okay. Yes, thank you. Thank you very much. I think first of all, on the issue of testing and employment of people found to be HIV positive, I think the WHO guidelines have been very clear and established over many years now that interventions, including testing for diseases, including HIV, need to be carried out with the consent of the person concerned. I think these are now the norms that have been established over many years. And so much has been learned about HIV that there are also recommendations that being HIV positive, with the kind of treatments that are available, particularly these days, which enable actually somebody who is HIV positive and who is on treatment and consistently taking their treatment not to be a danger of infecting others, that HIV positive status is not the reason for somebody not to be employed, employable, or to be dismissed from employment. I believe those standards were established many years ago, and our expectation would be that those would be respected. HIV is one of the areas where a lot of progress has been made in terms of access to treatment in many of our countries, and really with the tools available, it should be possible for all people who are HIV positive on treatment, on antiretroviral therapy, to be considered to be able to work. And many people have lived with HIV for many years and been able to carry out normal lives. Secondly, the issue of malnutrition in Kenya, yes, indeed, there is a very severe situation in the Horn of Africa, Kenya and the other countries in the Horn of Africa, of drought, which has resulted in extensive malnutrition. I would say that it's a situation that clearly needs the support of the international community, and we as WHO are working with our teams in those countries on the health aspects of this, together with other partners that work on humanitarian areas and organizations like World Food Programme that provide support to member states in the case of such such situations of acute hunger. I know that we are putting out appeals for international financing for the level of funding that is needed to respond effectively to such a situation. And it is our hope that these funds will be made available, and we will work to support the actions of the governments concerned, not only to provide food and prevent starvation of the population, but also to support the treatment of acute malnutrition in children, which is one of the roles that WHO plays in such a situation.
Thank you very much, Dr. Moeti. Dr. Fiona, do you have anything to add?
No, no.
Okay. I think it's been mentioned. The strong link between health and nutrition is clear, and it is one of the worst crises that we are experiencing in the Horn of Africa. Actually, the worst drought in the past 4 decades. So it is a concern for WHO. At the same time, the resources are quite scarce. We have put up an appeal for $124 million to support the response to that crisis. But only 21% of that amount has so far been funded. WHO has gone ahead to release some funding from the contingency fund for emergencies, and using those resources, there is a bulk procurement that has been done. We expect supplies to start coming in this early September to support the response activities on the ground. As mentioned also, while we are looking at the health component, the collaboration with the other partners, WFP and others that are directly responding around food security is going on. So it's a collective effort to really support Kenya and the other 7 countries in the Greater Horn of Africa to address this crisis.
Thank you, Dr. Fiona, for that addition. This next question is coming to you, Dr. Andre Bitter, and I would like to request if you would kindly respond in French. The question is coming from Maureen. She's from Wakat Sarah. What is the situation regarding the fight against meningitis, especially vaccination in Sahel countries? Dr. Andre Peter, please respond in French.
Merci beaucoup, Mary. Merci pour la question. Il faut dire que depuis pratiquement 5 ans, on a noté une réduction significative des cas d'épidémie et de décès et de séquelles liées à la méningite, pratiquement plus de 40%. Et l'Afrique de l'Ouest est spécialement concernée parce que c'est en Afrique de l'Ouest qu'on a pratiquement 80% des cas de méningite. Avec la vaccination qu'on a pu introduire et de très bons résultats, avec plus de 95% des cibles vaccinées, on a eu cette réduction. Donc, les programmes de vaccination et la population répondent positivement aux interventions de la méningite. C'est pour cela qu'on peut justifier cette baisse. Merci.
Merci beaucoup, Dr. Bitter. Professor Lafosse, do you have anything to add on this question?
No, that's fine. Thank you.
Okay, thank you very much. And this next question is coming to you, Dr. Moeti. The question is from BBC. What can the continent look forward to with the new malaria vaccine R21 now that it has shown good results? And Dr. Kali, you could prepare to complement as well. Over to you, Dr. Moeti.
Yeah. Yes, as I said previously, clearly this is very good news that there's a discovery of this vaccine, which is seen to have such a high level of efficacy. And I think what we can look forward to is eventually, once the data is finalized, the vaccine has gone through all the phases of clinical trials, and then field testing as well as was done with the RTSS vaccine, that it can be an additional tool to join the vaccine that's been found to have a reasonable level of efficacy, the RTSS, in reducing severe malaria and deaths in children. So we think this is only good news. I think there is still more work to be done in completing the series of clinical trials of this vaccine, perhaps on a larger scale, in looking at its field use. But I think this is very positive news that it can join the tools that are already available. We're very keen to continue with the work that is being done now to make available the RTSS vaccine, which has itself been shown to have a good efficacy.
Thank you, Dr. Moeti. Dr. Kalu, do you want to compliment? Okay, so let me move to the next question. And this question is coming to you again, Dr. Andre Bitter, is on meningitis. What is WHO's assessment of government strategies for the prevention of meningitis in West Africa, particularly in Burkina Faso? We would like you to respond in French as well. Dr. Andre, please.
Merci beaucoup, Mary, pour le passage de témoin, ainsi que les journalistes qui ont pu poser la question. Il faut dire que le Burkina Faso était l'un des pays les plus affectés en Afrique. Et depuis l'intervention, depuis les campagnes de vaccination, on peut noter que ce n'est que depuis en 2019 qu'on a pu enregistrer la dernière épidémie. Et l'État est très engagé. C'est l'un des pays où on a les meilleures performances grâce à l'intervention de l'État ainsi que des partenaires, y compris les travailleurs professionnels, et une bonne réponse de la population. Donc, l'exemple du Burkina Faso est souvent démontré dans d'autres pays et on voit bien qu'il y a une meilleure compréhension, un meilleur transfert de compétences. Donc, de façon globale, comme dans les autres pays en Afrique de l'Ouest, les programmes ont été très bien mis en œuvre, sont renforcés, sont monitorés avec une grande implication des autorités administratives, politiques ainsi que des autorités sanitaires. Merci.
Merci beaucoup, Dr. Andre. Dear journalists, please, if you could help identify yourself, your name and the name of the media organization you represent when you raise your hand, we will sincerely appreciate it. And now I'm giving the floor to Observer Times. I understand you're ready to ask your question live. Observer
Thank you for considering my question. This is Ashwin Barshinge from Observer Times, India. What strategy focused by WHO Africa on genomic knowledge and pathological characteristics of various COVID viruses with the monkeypox virus? Thank you.
Okay, Dr. Tiano Balde, are you there?
Yes, yes, Mary, I am.
Okay. Do you want him to repeat the question?
Yes, absolutely. Thank you. Thank you.
Yeah. If you can repeat the question, please, Observer Times.
Sure. What strategy focused by WHO Africa on genomic knowledge and pathological characteristics of various COVID viruses along with the monkeypox virus? Thank you.
Okay, genomic knowledge on the COVID virus and the monkeypox. Over to you, Dr. Tiano Balde.
Thank you, Mary, and thanks also for the question. I think the question is really most related, I mean, to the capacities that we have here in the African region, I mean, in terms of genomic sequencing, which can help both for the COVID-19, but also for other pathogens. So definitely, I mean, during the past 2 or 3 years, there've been a lot of increasing, I mean, in the capacities of almost all of the countries in Africa here in terms of genomic sequencing. we can say like that we have even surpassed, I mean, all of the sequences which were expected, like for the COVID-19 for this year. I mean, we are really doubling somehow the numbers that we were expecting to conduct in terms of sequencing of the COVID-19. So there have been a lot of capacities which has been built both at national but also at sub-national level, but including also at the more sub-regional level. So we are using some of the laboratories like KEMRI in Kenya or Institut Pasteur in Dakar for really trying to support as much as possible all other countries here in Africa for building their capacities. And this has been, I mean, used also, I mean, for the monkeypox as we are talking now, and also for many other diseases. So I think there are some ongoing action which are, I mean, that we are pursuing, notably in terms of training, in terms of experience sharing, in terms of learnings, I mean, across learning across the different countries. But it's really an area, I think, where there've been a lot of improvement, I mean, over the past 2 or 3 years. Thank you, Mary.
Thank you very much, Dr. Baude. And this next question is coming to you, Dr. Fiona Braka. Regarding is from VOA. Regarding the ongoing measles outbreak in Zimbabwe, what should be done to avoid repetitions in the future? And the second part of the question says, why does the outbreak appear to be spreading so quickly, and is WHO concerned? Dr. Braka, please.
Thank you for that question. Yes, indeed, WHO is concerned about the ongoing measles outbreak in Zimbabwe. It's the first in many years at this scale, and it's been progressing quickly among a community that's reticent to accept vaccines or modern medical care. The other concern is that the case fatality is relatively higher when compared to other recent outbreaks that we have witnessed across the African region. This outbreak started in April this year in one of the districts in western Zimbabwe, Mutasa, and it followed a large religious gathering. At that time, appropriate outbreak response measures were taken targeting the affected district, but the outbreak continued to spread, and we saw peak numbers in mid of August. As of the 6th of September, we have a cumulative total of over 6,500 suspect cases with 704 deaths that have been reported from that outbreak. And looking at those that have been recorded as suspect cases, close to 70% of them have not recorded any prior history of measles vaccination. So the major risk factor here is non-vaccination. It's mainly in a religious community that's known to object any vaccine. And we also know that with the onset of the COVID pandemic a couple of years ago, we had challenges with regards to sustaining immunization service delivery across many countries, including Zimbabwe. So many or some of these populations have not been reached, and they are actually residing in remote areas that are hard to reach. We are pleased to note that the country has started implementing a mass vaccination campaign nationwide, targeting all children between 6 months and 5 years of age. So far, from the reports we have, over 700,000 children have received the vaccine. And there's also discussion now to extend the outbreak response vaccination activity to reach older age group, those that are between 5 and 15 years of age in the worst affected areas. So vaccination is key. We've been able to stop measles outbreaks using high quality campaigns. But at the same time, routine immunization remains the bedrock for sustaining population immunity to diseases like measles. Thank you.
Thank you very much, Dr. Fiona. And Dr. Moeti, do you want to weigh in on this question and the previous one?
In fact, no, I just wanted to add on the previous question about genomic sequencing that we are noting the importance, having worked very hard with our partners to build the capacity in an emergency mode for genomic sequencing for COVID-19 in many countries in the region now. That and much of the work that was done was based on capacities that had been put in place, perhaps for other diseases, that it's for influenza, for other diseases, that it is very important as we build capacity in countries that we make these connections in the way that that resources are invested and that capacities are built up, so that we have lab systems that have some level of flexibility and can deal with a number of different pathogens and viruses for the purpose of building up these systems. So we believe very strongly in WHO in the principle of integrating to the degree feasible and possible some of the investments and some of the capacities, so that there is a level of flexibility and resources that had been invested for one disease can be turned over and used when there is an outbreak for something else. So that way of working on our health systems is extremely important. So this is what we'd like to encourage, so that altogether the investments to deal with different diseases can really have an impact that's more than the sum of each one of them if we make these connections and have a synergistic way of organizing the services where appropriate in countries.
Thank you very much, Dr. Moeti, for that addition. This next question is from Jules Kabore from Burkina 24. Professor Lafosse, if you could answer this question in French. Can we have the statistics on meningitis cases and the benefits of vaccination in West Africa? Prof?
Yes, could you repeat the question, please? And then I will respond in French.
It says, can we have statistics on meningitis cases and the benefit of vaccination in West Africa?
Yes. C'est bien assez facile parce que on a bien détaillé les nombres de cas de méningite de la souche A, et on connaît que avec l'utilisation du vaccin Menafrevac, on a géré l'immunité communautaire, c'est-à-dire la protection est bien amplifiée et on a réussi à minimiser à 0 cas quand on se sert du vaccin avec une couverture plus que 95% ou 90%. On a établi cette règle, franchement, dans une vingtaine de pays, et on est vraiment sûr qu'avec une couverture et avec l'introduction du vaccin dans le programme élargi de vaccination, on a arrivé franchement à éliminer cette souche. Et les données qu'on a reçues de Burkina Faso, du Niger, du Nigeria, franchement, sont des preuves assez importantes dont on a une grande confiance que la réussite vraiment a bien passé. Alors, avec tout ça, il faut aussi souligner que le futur va continuer. Et si on ne réussit pas à continuer avec des vaccinations pour être sûr que la souche ne peut pas se réétablir, on va avoir des problèmes. Mais à ce moment, les statistiques sont vraiment très impressionnantes. Merci.
Merci beaucoup, Professor Lafosse. This next question is coming to Dr. Fiona Aturube. Can you tell us what is the progress we have with the COVID-19 vaccination and why is the rate still low?
Thank you very much, Mary. So far we have 22% of the African population fully vaccinated with COVID-19 vaccination. We are talking of the primary series, and 29% that have received at least one dose of the COVID-19 vaccination. And this is in comparison with 68% globally, meaning we are still very far. Again, as Dr. Moeti mentioned, we have 70% target of we have a target of fully vaccinating 70% of the African population by the end of 2022, and we just have 100 days to go. So in the meeting that Dr. Moeti also referred to, that was co-convened by Africa CDC with WHO and partners and the different ministries of health from the member states in Africa here in Addis right now, we've gone into the depths of what is actually causing the low coverage. That one of the biggest issues is the low risk perception that is within the communities, given the relaxation of the public health measures. And this low risk perception has led to reduced demand for the vaccine. So the demand at the community level, but also the systems that are in place to reach adults. We have immunization systems that are used to looking after children and vaccinating children, but having specific strategies to vaccinate adults. For example, where do adults go? Adults go, we are talking of high-risk population groups, the elderly. These are people who are in their homes. These are people who can be found, for example, at churches or at mosques. These are not people we find in health facilities if they are not sick. But we also have people with comorbidities. So we are trying to have strategic alliances with associations, for example, people living with diabetes, people living with HIV, and where we get cancer institutes, where we find adults generally, which is not normal places that we do vaccinate. So those strategies to reach older adults, to reach people with comorbidities, and also healthcare workers. That hesitancy we saw among healthcare workers in Africa was unmatched when it came to COVID-19 vaccination. But now we have built the alliances with healthcare workers, and we plan in the next 100 days towards the end, before we reach end 2022, to ensure we have the healthcare workers and other professional bodies on board to help us become the opinion lead to their opinion leaders anyway in their communities, to ensure that we do really vaccinate the highest priority groups. Over to you, Mary.
Thank you very much, Dr. Fiona. And Dr. Moeti, this is a follow-up question from Paul Adepoju. You mentioned Africa could be the first to eradicate meningitis. What is peculiar about how the continent is fighting the disease compared with other regions? And what will you recommend regarding vaccination where Africa eventually eradicates the disease? Dr. Moeti, please.
Okay, thank you. Actually, I think that Professor Lafosse, who was such a significant figure in some of what was done to reach the virtual elimination of Group A meningococcus on the continent, could tell the story of what was done. Because I believe it's a story that's relevant for what we're doing today on COVID-19, what needs to happen now that we'll have a conjugate vaccine that's going to be applicable for different groups of the meningococcus. It really was a combination, as I said earlier briefly. It was a combination of financing. It was a combination of political will from the countries. There was a strong demand from the leadership of the ministries of health in countries for this support. There was a partnership of technical agencies with WHO, with PATH, and there was very much, as he himself said, work with the communities to create their understanding of the need to have their children vaccinated and to create a demand in the community. As you've just heard from Fiona, these are aspects that are also very relevant today as we talk about COVID-19 vaccination. We certainly need partnership. We need a kind of solidarity from those who have the resources to provide, and we need the demand at the political level and the demand at the community level. And then we need partnership between the technical agencies with the relevant roles and functions to put together the relevant expertise to make sure, first of all, that the vaccines are adapted and developed, and certainly that the work is done on a consistent basis, learning lessons about what it is that can help us to overcome barriers in making sure that we deliver the vaccine. The vaccines are available, accessible, and the reach of the campaigns and the services is what is needed. I believe these are lessons we're learning over and over again. And we've just heard from Fiona. This is exactly the conversation that's going on in this meeting in Addis Ababa today about COVID-19 vaccination and accelerating the coverage in Africa. So in my view, these are fundamental lessons of public health. What is needed to make sure that when a tool is needed, it is developed, it is invested in, and when it is developed and available, it is rolled out and provided to the population that needs it in a consistent way and becomes part of routine services in countries with improved health systems. I really think this is something that is very fundamental. As we know, vaccines are such powerful tools for disease control and public health. And the lessons that we learned repeatedly for different diseases are really lessons that we need to take into public health in all countries.
Thank you very much, Dr. Moeti. Indeed, vaccines, we have had a lot of good news today, from meningitis to malaria, and now progress with the COVID-19 vaccination. Professor Lafosse?
Yes, I would like to comment on 2 points. Dr. Moeti has summarized things very well, but I can recall when in 2008 and in 2009, we were at the latter phases of developing this vaccine, and it became clear that there was a major urgency, because at the end of 2008, there was a brisk outbreak in Nigeria, in Sokoto, that soon became the following year the beginning of the last MENA epidemic, hopefully in Africa, where unfortunately there were over 80,000 cases that occurred in northern Nigeria and in Niger. This brought enormous pressure on the project as it was finishing its studies of the vaccine. And it created in the project a sense of urgency that what was being done was truly important. And it's hard to get away from that awful event that is those 80,000 cases, because they essentially lived with us as we worked very hard, as all of us worked to actually get this work done. So that's point one. Point two, we learned through the project, and particularly through the introduction of Benafrivac in Burkina Faso, that the vaccine would have a major effect on carriage. And I would say that was the other piece of scientific information that really has proven to be very powerful. And that is that with vaccine coverage rates that are very high, one can eliminate the circulation of this organism in the posterior nasopharynx, that is, amongst carriers that are not ill, but they're basically circulating the organism. And we learned that with high vaccination coverage rates, this carriage can fall to zero. And once it falls to zero, whether you're vaccinated, whether you're unvaccinated, you will not come down with this disease because it no longer exists in the community. And I remember that when we introduced the vaccine and we had these first results from Kaya, that I was looking at what was happening in Burkina Faso in the spring of 2011. And I was very, very worried that we might see cases in under ones because the vaccine was being used in individuals from 1 to 29 years of age. And so I spent a great deal of time at the Charles de Gaulle Pediatric Hospital in actually reviewing and seeing all cases, particularly in under ones. And I was gratified to see that there was not a single case of meningitis due to group A disease. Rather, it was pneumococcal or Haemophilus influenza that was causing these cases of disease. And so those two facts put together meant that if we introduce the vaccine in 1 to 29-year-olds with high rates of acceptance and a good communication plan, that we could have a major public health effect. And that is precisely what happened. But it would never have happened without the thousands of vaccinators that made sure that the coverage rates and the acceptance of this particular vaccine was high. And so along with Dr. Moeti's points that are all correct, I would just underscore those two observations as being really particularly important in terms of understanding what happened in Africa. Thank you.
Thank you very much, Professor Laforce, for reinforcing this good news about the fight concerning meningitis using vaccines. We have definitely come a long way in this fight. And now we are coming to the end of this presser for today. I will turn back to our panelists to give us their final thoughts. So I'm starting with Mrs. Roda.
Yeah, I want to encourage every one of us on the fight against meningitis. We should understand that meningitis is a race against time, it's an emergency situation. We should play our parts. Donors should take meningitis as a part of their intervention. Same way they've taken HIV/AIDS, they've taken tuberculosis, they've taken malaria and COVID, meningitis should also be a priority. In other health issues, we know when it happens, the sequelae are not the same with meningitis. So please, I appeal to everybody to be in the race and for donors to integrate meningitis as part of their intervention. I equally appeal to governments to provide social funds for survivors of meningitis because there is presently no care and support in most of the places I know about in Africa. There is no provision for care and support. Civil society should be highly integrated into the role of defeating meningitis. Thank you, everybody.
Thank you very much, Mrs. Roda. And turning now to you, Professor Laforce, your final thoughts, please.
Now, my final thoughts are the future is very bright. We have products that are coming. We have learned lessons on how to use these particular products. I think that we are poised to do something quite important over the next 5 to 10 years. Thank you.
Thank you, Professor Laforce. And finally to you, Dr. Moeti.
Yes, thank you. I mean, first, I'd like to really sincerely thank Mrs. Rhoda and Professor Lafosse for having joined us and shared with us your experiences, your analysis and your recommendations. So starting with survivors of meningitis, thank you. I think we all need to realize that sometimes in our concern for closing down outbreaks, we do not pay sufficient attention to the people who've been affected and what happens to them subsequently. And I know that such supportive services are not very strongly established in our region. So it's just to remind all of us that whatever good tools we have, there are people who are affected, and there is a need to ensure that there is care for these people in working with not only in health, but also with the social sectors in our governments to ensure that packages are put in place to support people. And as Mrs. Rhoda said, working with communities to make people aware of the symptoms, of the impact on lives, of the need to get vaccinated, get your children vaccinated is one of our key responsibilities. And for this, I'd very much like to appeal to and thank our colleagues in the media. That this is what we hope that you will continue to help us to do, to create the demand for these services when they are available. And then finally, to thank Professor Lafosse for sharing your rich experience and your reflections with us. I agree very much that the future is bright, the optimism is there. We are living through a very difficult situation, or we have lived through a difficult situation, the COVID, which has negatively impacted all this, which teaches us that we need to be ready to deal with multiple challenges at the same time. And to finish by saying we need then to invest in systems to take on board the lessons learned about partnership, strong systems, investment, communities that are really going to be the core of public health in the future. And of course, continuing to learn. I believe that with each outbreak, with each intervention, with the results that we see, we learn to know what to prepare for and how to do better as we face the next challenge. So I'd like to thank very much our colleagues from the media for having joined us, and exhort you to continue the good work that you are doing in spreading information around. Thank you.
Thank you very much, Dr. Moeti, and a very thanks to all of you, our great panelists today, and the journalists for your contribution in the fight against infectious diseases, both on the continent and globally. A very big thanks to all the team of experts and the communication team. So we have come to the end of the briefing for today. Thank you very much, and do have a nice day.
Thank you.
Thank you. Bye-bye.
Thank you. Bye.